So I'm Patrick Marr. I'm part of the program committee. To start off this session, we've got a great team. First, I want to introduce Carly Easton. She's an associate professor of emergency medicine at the University of Arkansas for Medical Sciences.
Thanks, Patrick. I'm going to share my screen here. So welcome everyone to our National Journal Club. We appreciate all of your interest and engagement here today. This is the first National Journal Club that is being put on behalf of the Evidence-Based and Healthcare Implementation Interest Group. So we're excited about this. There we go. I'd like to introduce all of our panelists. We have Rebecca Richards from The Ohio State, Brian Kane from the University of South Florida, Ben Hunter from Indiana University, Corey Chumpentazi from Baylor, Sanjay Lee from University of Iowa, Dan Mayer actually could not be here, I apologize, Joshua Davis from University of Kansas, Wichita, Barney Eskin from Morristown Medical Center, and John Kirshner from Indiana University. We have no conflicts of interest. So our objectives today are to demonstrate an effective journal club, and what we're going to do is actually go through an article in real time. We want to introduce a PICO question and review the relevant evidence-based principles. We want to facilitate small group discussions, and this will actually demonstrate the journal club principles, focusing on critical appraisal of an original manuscript. And then we will propose an answer to the question, will you change your practice? So first, I'd like to introduce Dr. Ben Hunter, who is Professor of Clinical Emergency Medicine at Indiana University, and he's going to talk about what are the components of a successful journal club.
Hey everybody, thanks Carly. So we've just got a few minutes, but I think it is valuable to talk about just a few of the things that hopefully bring people to your journal club and get people interested and wanting to come back every month or however often you do this. So when I think about a successful journal club, I think like the participants are interested, they're involved, and hopefully at the end you've made some impact, potentially on the way people practice. There's a couple ways you can have impact. One is, the way people read literature. Obviously we want to teach people how to read literature better, but ideally the most kind of stimulating journal clubs also impact people's practice. Next slide. So at least in my opinion and talking to a lot of other people, I think there's decent agreement here that running a successful journal club usually requires a champion. I think you can have more than one, but the idea of like spreading a journal club out amongst all of your faculty or a bunch of residents rarely really results in a continuous and consistent cohesive journal club. So having a champion or a couple of champions, I think is really key. Obviously, you want your champion to be someone who understands critical appraisal and evidence-based medicine. I think it's also important that they are a clinician who understands the clinical impact of what you're discussing and what these studies actually mean and how to take them. Really need to take ownership of the journal clubs. So again, I think in terms of what's going to make your journal club successful, most of the time, I think a great question leads to a great journal club. If people are really interested in what you're asking, really interested in what the evidence tells them to do, it's always a better journal club, even if everything else seems to be going wrong. I prefer to kind of let my learners decide what the question is. Sometimes they'll need some guidance on that. But I don't think it has to be done that way every time either. Another preference of mine is to let them kind of come up with a question, usually based on something they've experienced clinically, rather than kind of skimming through New England Journal for the most recent big paper that has any ED relevance. Again, I think people have different feelings this way, but I think people really get into it when it's something that they've actually experienced. They've had this kind of struggle or difficulty on a shift, and then they can kind of bring that to the journal club and to their sort of approach to this question. Next slide. In order to get involvement, generally, you're going to need smaller groups, right? You know, I'm at a place where we have, I don't remember the exact number, but somewhere on the order of 75 residents. And 75 people are not going to get involved in a discussion in one room, right? So you're oftentimes going to have to break down into small groups. Some places, if you're just a fellowship, or if you have, you know, a smaller residency, you may not need to do this. But oftentimes, you'll find 2 or 3 papers that are really relevant to your question, and it works out nicely to break into those, you know, 2 or 3 different groups. But even if you only have one article to look at, I think it's important to end up with the right size group so that everybody feels like not intimidated to get involved and answer questions and participate. But one thing you got to think about here is that in each group, you need somebody who really knows what they're doing and has really already gone through the paper to lead that discussion. So, you know, if you have 5 small groups, you're going to need at least 5 people who understand the study already and are capable of leading through, you know, a critical appraisal and everything like that for that study. Next slide. And then impact. And this really just comes with having like a good question, I think. But one of the things that I've seen drive like learners crazy is at the end of a journal club, everybody just says like, well, these papers are trash and we don't know anything. And like, that's not very helpful for people who really, you know, a few of these people at your journal club are going to be interested in evidence-based medicine and they enjoy the process of, you know, trashing a paper and finding all the weaknesses. But almost everybody there is going to be a clinician. And what they really want is to be able to go back to the bedside and say, well, I'm going to do this. Maybe the evidence is weak, but at least I've looked at all of it and this is what I want to do. So I think it's important as you're preparing to have kind of a stand. And that stand may be weak. Like, I'm not sure one study could change my mind, but this is what I'm going to do based on what I know. Next slide. So in summary, I think you need a champion or a couple champions. Have a system for how you're going to choose questions. I like to let that system involve learners and encourage them to pick clinical scenarios rather than just skimming for a paper. Know how big your group is going to be so that you can divide accordingly and arrange for like the right number of, you know, small groups if needed. And remember that most people want a clinical bottom line. Most of the people there probably want the clinical bottom line more than they want the actual critical appraisal. I think those are the important things. So thanks.
Thanks, Ben. So now that we know the components of a successful journal club, we're going to launch into our journal club. So Dr. Joshua Davis, who's a clinical instructor at University of Kansas, Wichita, is going to introduce our PICO question.
Thanks, Carly. So a little bit about the PICO background. Hopefully most of you are relatively familiar with this, but if you want to click through these, you know, PICO stands for population, intervention, comparison, outcome, and time. A couple things to just remember about kind of when you're looking at these components and this kind of framework for looking at a study. The population, you want to look at whether that is relevant to your population that you kind of treat on day to day, and that may be very different across different, you know, for example, this group, we may have treat very different populations, inner city, rural, United States, European, very different populations. So you need to question whether you think that that's applicable to the people you treat. The intervention, I think it's important to look at the practicalities of the intervention in addition to what exactly the intervention is. So what's the dose? How is it given? We'll see a little bit about that in the study that we're going to look at today. The comparison, so was it blinded? Is it placebo controlled? I think that's going to be an important thing to look at when you're looking at how strong the study is. The outcomes, so clinically relevant outcomes versus surrogate outcomes are always kind of preferred. And then, you know, patient preferred outcomes are also preferred over, you know, laboratory marker improvements and things like that. And then time, obviously. So is this a relevant time frame? So the classic one that we always talk about is in heart attacks and myocardial infarction. We look at kind of 30-day MACE or CRACE, and so you want to look at a relevant time frame. You don't really care in emergency medicine. I don't really care about necessarily their kind of 5-year outcomes necessarily. So several options for kind of critical appraisal tools to help you decide and analyze the articles. You can use any of these ones listed here, SGEM, AHRQ. We happen to choose the Annals of Emergency Medicine one here. I think when you're picking one of these, it's important that you pick one that is brief enough that it is relevant, also has some flexibility. So for those of you who want to look at the Annals of Emergency Medicine one, if you click here, there's going to be a little QR code that comes up in the bottom. If you didn't have access prior to coming on the call, or the link that's in the description, you can access the critical appraisal tool. I'll show it to you here on the next slide. So this, as you can see, is relatively short, very kind of oriented towards outcomes and clinical outcomes and study strength. We're going to use this as the framework for what we are going to analyze in our study today. For those of you who couldn't get on the QR code, there's a link on the bottom here. It's a relatively simple link to put in. You just click the therapy option because that's what we're looking at today. It's a nice example of how there's flexibility though, because if you go to that Annals of Emergency Medicine website, they have different tools for different study types. So diagnostic studies and observational studies and then therapeutic studies. So it has a lot of flexibility along with it. So the study that we're going to be doing today is the effect of, we're just going to say BAM as monotherapy or in combination with atezolizumab on viral load in patients with mild to moderate COVID-19, a randomized clinical trial by Gottlieb et al. This was put out by the Eli Lilly's group looking at outcomes. I think many of you may have read this before. For those of you who didn't, again, you can type in the title and access this, or you can use the QR code there in the bottom. So our PICO question today is looking at adults with mild to moderate COVID-19 is the population. Our intervention is IV bamlanivimab, or BAM. Our comparison is IV placebo. The outcomes for our PICO question today are clinical outcomes, so hospitalization, intubation, ICU admission, mortality, and the timeline we're going to look at is 1 month. It's important to remember those outcomes when we analyze the study in detail for those of you who have not read it yet.
Thanks, Josh. Okay, so I'm just going to do a minute or two on the background of BAM. So for those of you, I think many of us have, used it or had it as an option in our hospital. But what is BAM? It's an anti-spike neutralizing antibody, and it was initially studied in inpatients, but found to have no benefit. But they did an interim analysis on this randomized controlled trial that we're going to look at here in just a few minutes. The New England Journal of Medicine published this interim analysis, which is posted here, and that led to the emergency use authorization by the FDA in November 2020. And so that is how this all came about. And then subsequently, they published the randomized controlled trial. And then since then, there have been multiple iterations of the EUA, but has since been revoked. And the main reason for it being revoked was that because of all of the variants, the BAM has not shown. You can see here the fold reduction susceptibility basically reduced significantly with the variants. So they revoked the EUA. And so currently you can only give BAM in combination with atezolizumab. So we're going to focus mostly on the combination therapy in our breakout rooms. So for all of the participants, if you could look at this list of groups, we're going to have 5 breakout rooms. And if you could organize yourselves by first name. And
actually, Carly, in re-looking at the participants, we can reshuffle to have 2 facilitators and 2 participants in each room. So I will assign those and open the rooms.
Okay. So we will go ahead and start going through the article with you.
And once I get there, it is. So have you all had a chance? Have you had a chance to read this at all before, or are you familiar with this article at all?
Yeah, I have some preliminary readings of them.
Yeah. So the goal here is just really to demonstrate how to do kind of small groups and stuff. All of the details of the actual kind of clinical stuff is kind of secondary here. So I have both the article here, and then I have kind of our kind of therapy form, you know, our critical appraisal form filled out already for us to kind of look at. So I pulled I had us pull some of the relevant information here. So the article being reviewed here. The first question in the critical appraisal form is, you know, were the patients randomized? So I think, you know, this is where we can look and see that they were actually randomized. If you look in the very detailed sections, it's kind of the exact how they were randomized it says they were kind of centrally randomized using this interactive web response system. It's not really clear exactly all the details of that, but it's pretty clear that they were randomized using this kind of figure. I don't know if you've had it, if you want to have a chance to like look at all the kind of other details and stuff in the study as far as concealment and stuff. This is a pretty very deep in the kind of supplement is the concealment kind of protocol, and it's really not even that detailed, but just that the patients and the investigators were kind of blinded as far as we can tell based on the information that they gave, and that they use kind of, you know, these opaque envelopes and central randomization. So Jesse, I'm going to let you look at, you know, were the patients analyzed in the groups to which they were randomized, and I'll let you kind of chime in there as to what you think on that. I don't want to hog the microphone.
From what I remember when I was reading it, I think they did an appropriate job. I forgot what the N was, 592. So I think they were appropriately randomized, and I think according to the inclusion/exclusion criteria. So that's how I remember from reading the article.
Yeah, no, I agree. They were largely randomized correctly. I think this next question is getting at kind of dropouts and intention to treat. And I do think there's a little bit of some minor discrepancy here. I'm not sure how much it distracts for the whole study, but they did not do an intention to treat. So patients who didn't actually get an intervention were not actually included. So patients who, if you look kind of here in this kind of figure that they provide, patients who did not receive the intervention because they withdrew or refused it were kind of taken out of the study. Seems a little bit unequal in the kind of group sizes as to how many that was in each group. So may introduce some bias. So you can see here that like 5 people withdrew from the placebo group, whereas only 2 people withdrew from the combination group. And when you have a sample size of 100, that could introduce some bias. And then also people who didn't have their viral loads kind of done. Also here you can see there's a little bit of a misbalance, not between the placebo and the like combination therapy group, but between the placebo and these smaller bamlanivimab smaller dose monotherapy groups. So, let's go down.
The other big thing to remember with intention to treat is that if you do not do a true intention to treat, which is analyzing groups in which they were randomized, then you lose some of your randomization. And so you want to make sure that it's not a large proportion of your patient population, because otherwise you don't really have a randomized population anymore. You have kind of a cohort. So
yeah, and just,
it was relatively small numbers.
My personal experience with that, having done some trials before, is you actually lose a lot of minority groups in the kind of withdraw and like not lost the follow-up, and so you know, that kind of goes to that point too. You can lose some of your randomization aspect when you do that. So were the patients in the treatment and control group similar with respect to known prognostic factors? Jesse, do you remember that from what you read?
I think they were similar.
Oh, I went too far.
Yeah. Let me pull up the article.
Yeah, so this is, yeah, you can pull up the original article. This is the table taken out of the article. So the classic table 1 of every article kind of has all those demographic characteristics. I always appreciate when they like put a p-value on the side so I can like tell whether stuff's significant or not. But sometimes you just have to look and be able to eyeball it. You know, I think the big ones that we know of are age, BMI, and then you know, they just grouped everything as risk factors for severe COVID. You know, I think that's, you know, diabetes, heart disease, blood pressure.
I did notice that when I was reading this article, the percentage of ratio, self-reported race, it was proportionally pretty high amongst the Caucasian, and the minority group were quite sparse.
Yeah,
but
you see that in a lot of studies. I think.
Yeah.
I mean, I don't know how you. I mean, I don't know about kind of the Asian experience and stuff, but I remember learning about like Tuskegee and stuff like that. And my experience is I mean, that thought process is still very pervasive.
Right.
But I think to Jesse's point, it does go to like the applicability of the study. So like if your patient population is not 90% white, then, you know, you may have some trouble applying the results of the study to your patient population. So here in Arkansas, in terms of my COVID patients, it was certainly not 90% white. So it does create a little bit of a difficulty in the applicability there.
And I was just looking at a couple of abstracts prior to this session where I believe there were studies from UCSD that the Hispanics actually had higher rates of COVID-19 than the general population. So it would have been nice if they were able to have here. But here, I don't really know what this means. There's 49, is that 49% or 49 Hispanic and 52 non-Hispanic in self-reported ethnicity?
I think that's the N, and then the percent value is in
parentheses. Yeah.
In parentheses, yeah.
So that's a breakdown of the white race. Is that how it was broken down?
Typically, when you do studies like this, they're just two separate questions.
Right.
So race is independent of ethnicity. So everybody who's included answers the race question, and then everybody answers the ethnicity question. But those are really high numbers.
Yeah.
In it.
That doesn't, yeah, I don't know how, yeah, how that comes to 49% or 48.5%. When it's white is 89 point. Yeah, that, I don't know, you know, that number seems kind of off to me.
So moving on to our next question. Did the experimental and control groups retain a similar prognosis after the study started? So we're 5 important groups: patients, caregivers, collectors, adjudicators, and data analysts blinded to the group allocation. So this is an important aspect that's kind of brought up here, which is that like, it's not really just double blind that we need to be worried about. There's lots of other people in the group that need to be blinded. This paper, again, as I said before, doesn't give a lot of detail about that. It says the pharmacists were not blinded, but it says that they didn't do anything else. So it's hard to interpret whether that played a role. I mean, the investigators and or the participants being unblinded means that the patient was removed from the study. So, so those are the two kind of major ones, but I think there's other ones that can also play a role, especially since this was a pharmaceutically funded study. So you might have some people who have some conflicts of interest. Aside from the experimental intervention, were the groups treated equally?
I think they were. I didn't see any. I don't recall there were too much discussions in that area.
Yeah, this one's a little tricky because you kind of have to get into the supplement, which is a little trickier to do, but they really didn't comment on if patients got other potential COVID therapies like steroids or at the time, you know, hydroxyurea was still being used, or not hydroxyurea.
Hydroxychloroquine.
Hydroxychloroquine, thank you.
Yeah.
Was still being used. And so they allowed those other treatments, but they didn't, you know, measure it. And so that's an area that, you know, we don't really know if the groups were treated equally because they didn't measure who got what other treatments for COVID. So.
Hopefully you would hope that randomization would take care of it, but it would be nice to have a verification of that.
Right, and because we know that those other treatments don't help, particularly steroids don't help without patients, and hydroxychloroquine has been debunked lots of times, then it shouldn't change anything because they don't work anyway, but just something to think about.
Was the follow-up complete is the next question. So I think we kind of discussed already about the kind of follow-up and which patients were removed. So we had the ones that were initially removed in the first round because they didn't receive the intervention. And then technically when you read this study, the primary outcome is viral load, and you know the clinically important outcomes are kind of secondary outcomes. So the authors removed patients who didn't have their second viral load measured, and they didn't include those in the analysis of anything else. They don't make it super clear. You know, it's not spelled out explicitly how they do that, but doing some simple math here, you can figure out kind of what they did and where those numbers came from. So there's a sentence in the paper that says there were 533 patients who completed the efficacy evaluation, and that's the 92.4%. So the 577 were the ones who withdrew, and then the 533 were the ones that were left after, like the patients who didn't have their viral load done. And so this is the kind of details of what patients got left out in that kind of second portion. Again, I think we kind of talked about that already. Okay, so now we get to the fun stuff, the results. So we talked about how large was the treatment effect. So, you know, in evidence-based medicine, we like to sometimes use number needed to treat, or NNT. It's a nice number that gives a tangible. As I mentioned before, their first line thing was looking at viral load, which is, I mean, lots of studies have been done looking at viral load, and it doesn't always correlate with any other kind of clinically significant outcomes. So there's this pretty rainbow chart here.
I think it's important, you know, like you said, when you're looking at the study's primary outcome, did they choose something that's patient-centered or even clinically oriented? And here, you know, I think most of us could care less about viral load. And so it's interesting that this EUA got published based on a primary outcome of viral load, which showed really no difference in any of the groups, I think at 11 days. So.
I wonder if they receive any direction from the FDA, if this was something that the FDA was looking at, or the company decided on their own.
I think Eli Lilly decided on the primary outcomes.
Yeah, I wouldn't be surprised if they picked that primary outcome because they thought it had a higher chance of being positive.
Yeah.
And interestingly, you see here, like, there's not even really a dose response effect that you can appreciate. Perhaps the kind of combination has a very mild effect there, definitely not anything statistically significant. So that's interesting. And then when we look at the patient-oriented measures, which is kind of what we really care about. So this is the major one, which is, had a hospitalization or emergency department visit at day 29. Very low numbers here. But I think a visibly significant difference when you look at the placebo group, which is 9 and, almost 6%. And you look at all these other groups, which is 1 or 2, which is, 1 or 2%. And, there's a visibly visible difference. That being said, it was a secondary outcome, so that's not what the study was powered to look at. And so then you have all of these non-really statistically significant outcomes. You can make an argument about whether 0.049 is statistically significant when you're doing multiple measures of multiple things, and this is a secondary outcome. You should probably do some sort of correction for that. So.
And the other thing that we like to talk about that's kind of a newer thing that we talk about with results and significance is the fragility. Are you going to talk about that?
I wasn't, but I'm glad you are.
Yeah, so the fragility of these results. So this combination group has this p-value of 0.049 showing maybe that there were fewer hospitalizations or ED visits in the combo treatment arm. But if you look and you take maybe one subject from the combination arm and you have them have a different outcome, then it makes it not significant. So that's considered to be to have high fragility. A high fragility index, I suppose, is what you could call it, when the results are prone to change significantly based on just a few subject outcome changes, which is not considered to be a good thing in EBM. So the fact that one subject could change the entire outcome of this paper in terms of these clinically oriented outcomes is not good.
Yeah, and I just noticed that even though the study had more than 500 subjects, only 97, is only about 100 is really in the combination arm.
Right.
The rest were just the single monotherapy. So really the current EUA is based on just the small population.
Yeah, it's like 260 patients.
Right.
I think. So it's really kind of fascinating that it got approved.
Interestingly, if you look at this complement, to complement what you're saying about the fragility index, I mean, even if the sample sizes were the same between the monotherapy and the combination therapy, then it would not be significant, right? Like if you had the 101 was the sample size instead of 112, it's just that it has a slightly higher sample size, that there's a difference there.
So if we had those subjects that did not get lost to follow up or got excluded, then we might have totally different results.
Exactly. And then the other thing that's really interesting to me is that there's not a dose response curve here at all. And so, you would expect that higher doses would have better outcomes, and that doesn't seem to be what's demonstrated here. So moving along. I went by the number needed to treat. Sorry, I skipped past fingers. So looking at the numbers here, we got a number needed to treat of 23. If you're looking at bamlanivimab alone, 20.4. If you calculate it out for the combination therapy, so 21, rounding up as the number needed to treat here. So I think that's, an important thing to consider.
But again, the fragility of that number is not good. Plus, if you can look at the confidence intervals of that NNT, and it's quite wide.
Mm-hmm. And then this is about symptom resolution, which is a patient-centered outcome, probably not as significant as hospitalization. The other thing too that I just want to point out about the combined hospitalization and ED visit, which I think a lot of people take issue with because you don't know which one. I think it's a big difference to go back to the ER ones versus actually be hospitalized for your disease. And I actually have reached out to the authors of this study, and they won't give you the data on it, even though they say that it's because it's under review still, even though they've revoked the EUA on it. And then so this is about, kind of symptom resolution, which you can see. I'm going to move this a little bit so we can see the end of this table. So looking at kind of symptom resolution, you can look at the NNT. You can kind of calculate the different kind of NNTs here, but largely not a significant difference in any of them. Some of them are kind of close, but none of them are really significant. The one that is significant is, this one here at day 11 for the 700 milligrams of BAM monotherapy, which doesn't make any sense compared to everything else that we know for all the other data. So it suggests that it's just an outlier.
And Josh, just to follow up on that, we really only want to calculate NNT on significant results. If it's not significant, then there's no real point in calculating the NNT.
Yeah, and then this kind of note here, the interesting note that at day 7, the placebo outperforms the 2,800 milligram dose. So again, suggesting that this is all, very, very fragile and probably not super significant. And then this goes to this next question here, which is how precise was it? So you look at the confidence intervals, and the confidence intervals on this are quite large because you have the outcome is 1 in a lot of these groups. When you're looking at hospitalization and ER visit, 1 in is, you're going to get a super wide interval when you look at that. And you'll see a lot of them overlap. So then the kind of clinically relevant stuff here, how do you apply this to patient care? I think, the external validity, as we talked about, and I talked about in my kind of talk earlier, it really depends on what your patient population is. So we talked about the largely white population. Most of these, as you can see, most of these are, United States. So this is all done in the US. So I think that also kind of plays a role as well. So may not apply to people in different areas of the world. I think the other thing that kind of comes up to is the practicality of this. So, an IV infusion is not easy to set up. And I think those of us that have access to this have realized that it's not. And so in addition to the actual harms of infusion reactions and stuff like that, I think you have to also consider the driving to the kind of site and stuff like that.
To give a really brief summary about what you talked about. We can start with Josh from my group, and then we'll go to Barney.
Yeah, so I think some of the important points that we highlighted are that we looked at kind of the demographics of the group and noticed that it's a largely kind of white and highly Hispanic group, which may not apply to certain people's kind of populations. And then one of the other things that we talked about was kind of the fragility of the data. So the fragility, we brought up kind of fragility index, and that there's one outcome or two outcomes that could very much kind of change the way that things swing. And then also that this was the secondary outcome of the analysis. And so it really wasn't powered to find that outcome. And so making a lot of decisions off of a secondary or hypothesis generating outcome is probably unwise, although it's the best data we have to date. And then I think
and he's referring to the ED visits and hospitalizations outcome.
Yeah, sorry. Yeah, I should have mentioned that, the kind of clinical outcomes. And then the other thing too would be helpful to know, I think, we brought up, it would be helpful to know the difference between ED visits and hospitalizations, if everybody died in one group versus, all the rest of the outcomes were repeat ED visits because my sniffles have gotten worse. I think that those are two very different outcomes. And so that was some of the major points. I'll leave some discussion points for some other people too to bring up.
All right, from Barney's group, somebody want to chat?
Yeah, I think we kind of hit on a bunch of similar points in group 1. There was certainly some concerns for the surrogate nature of the primary outcome, and again, we cared a lot more about more patient important outcomes. And the other points, the interesting points that we brought up in terms of using this article as a teaching point, as a teaching evidence-based medicine tool, would be to sort of challenge learners to try to explain the results of the trial in lay terms to how they would explain to a patient. Would be a good way to kind of finish that session, which we did not attempt to do.
All right, group 3.
Was that us, Carly? Our group
think so.
number changed.
Yes.
Okay. Yeah, similar points. You know, lots and lots of outcomes, essentially almost none of them statistically different. They tried to focus on one group out of 4 intervention groups that had a slightly statistically significant difference over placebo for one outcome, which is not unlikely to occur just by chance alone. The fragility index of 1. There were some baseline imbalances that favored the combination group over placebo. We felt like the, you know, very small difference in one outcome of interest that was potentially explained by the kind of flaws and imbalances of the study itself.
Great. And Brian, do you want to say something from your group?
So our group started and spent a few minutes exchanging ideas on how to engage learners and actually use the CAT form and get them to do it ahead of time. I wish we could say we figured out how to entice the residents to do the CAT form ahead of time, but we were hoping one of the other groups had figured that out. When we went through the article itself, maybe we're a little too skeptical, but we didn't buy that what they were selling about intention to treat.
Mm-hmm.
It seemed that in figure 1 that they didn't treat everyone or include everyone in the analysis they intended to. And then we got really hung up because we could not find 20 patients. And we were quite worried that if we had lost 20 children on a school field trip, that would matter. And I have to be honest, it went off the rails there for a little bit, but to find issues like that really had us question. And in the end, our conclusion is very similar to the other groups, that we were not impressed by the magnitude of effect. And we really didn't think on the next shift this was going to be something that we were going to be using a lot. And Rebecca, please correct me if I in any way, shape, or form misrepresented the group.
Perfect. So I think, you know, this is a good exercise in going from start to finish of a journal club session that can be engaging and have really good discussion, even if you don't follow your original plan perfectly, kind of like group 4, you can still have a really intense discussion about specific methodologies or what is intention to treat and how do you really figure out if they followed the rules and are they, you know, being transparent in what they really did. The other thing I don't think many of the groups mentioned that's really important in EBM that sometimes can get forgotten is the role of the industry in the study. And so that's something that everyone wants to remember is Eli Lilly was highly involved in the plan and the protocol in the study. And so that can create a lot of bias in the results too. So, so from all of our groups, what was your overall conclusion? Any of the, I guess I don't think the participants can talk in the main session, but let's do a thumbs up or a thumbs down. Is anyone going to be using either combination for their patients with COVID? No?
Dr. Carpenter's a yes.
Yes?
No, I answered before she asked the question. I thought she was saying, can we use any of the lessons learned in this session? No, we're not using BAM.
No, we're not using BAM. I hope that you will use some of the lessons that we went over in this session on how to, you know, facilitate a successful journal club and how to create one that can be engaging for your learners, because EBM is sometimes a dry subject, but it can be fun and engaging. Any questions from anyone? Oh, and we created this QR code for the completed critical appraisal form for everyone, so you can have a copy of that. Anyone?
I have a question. Are your institutions using BAM? Because I will tell you that we are using the combination, although I myself am not.
We've pretty much gone away from it, and yeah, so I know that the family medicine clinic or some of the clinics might be doing infusion clinics still, but in the ED, we've gone away from it completely.
We started a telehealth unit from scratch at the dawn of COVID after discussing that for a decade. And the telehealth people struggling to get a market, patients to come to telehealth, said we'll open a BAM clinic to get people to come to telehealth. So there was an idea there that we put the kibosh on.
Our ID folks love it. We have an infusion clinic set up right next door to the emergency department that they want us to refer people to, and they will call them and set it up.
Similar, Josh, our infusion is in our OBS unit in the ED. They definitely have a motivation to use it.
We've done both. We started with an infusion clinic, and then they moved it into our former OBS area. Love it.
Yeah, we stopped using the monotherapy, and then they actually transitioned to a different dual and monoclonal antibody that we still have access to in our ED.
So I think that highlights the difficulty in translating, you know, EBM and the literature to the bedside, because a lot of people just don't understand how to look at these articles and appraise them in a critical way and understand the flaws and really be able to say, does it make sense to even do this? Even though it's free to the patients, you know, the government is spending a lot of money on this. So, and it's
Charlie, our group had talked that the rational clinical exam, or not the JAMA Users Guide series is incomplete with these critical appraisal forms, because the last question should be, how are you going to explain this to your patient? And ask the resident to now tell you, act like you're the patient at Journal Club and explain it back to you to get through that level of difficulty, because that is the next stage of understanding when you communicate it to a patient, this complexity. And that should be on all the user's guide forms at the bottom.
That's such a great point, Chris. And in our standard Journal Club curricula, we actually, as an EBM skill every year in April, go over shared decision-making and communication with the patient. And we'll review articles that go over SDM tools or skills like that. It's so important to be able to discuss this.
well, I'm just catching up on the chat, but any other questions that we've missed? I want to thank all of the facilitators today and the panel for all their time and putting into this and the preparation. And I had a good time. I wish we had, you know, a lot more people come, but I had a great time, and hopefully we can do this again next year. Any other questions?
Thanks, Carly, for great work in organizing this.
You're welcome.
Yeah, this was great. Thanks.
Good job.
Thanks, Carly.
Thank you.
Thanks, Carly. Good work. Thanks, everybody.